A very warm welcome to this talk. I'm going to talk about the approach to neurodevelopmental regression. While I was preparing for this lecture, I was a bit confused because this is such a broad area, literally such a broad area that even within pediatric neurology, this is considered to be a super specialty. There are pediatric neurologists who are super specialized in neurodevelopmental regressions, and they are the ones who usually deal with kids who have got some form of neurodevelopmental regression. But nevertheless, I mean, in this lecture, I would try to summarize this whole thing in one lecture in such a way that would make you understand that how to suspect neurodevelopmental regression, and if you suspect neurodevelopmental regression, then how do you take it forward, and especially in the context where you are working in a district general hospital. I mean, I can understand somebody who is working in a tertiary university hospital where they are actually dealing with neurodevelopmental regression cases. They have got so many tools like at diagnosis. I mean, if you talk about fibroblast culture and the enzymatic assays, nobody does that at a district general hospital. So how do you use a simplified approach to ensure that you are dealing with some subgroups of neurodevelopmental regression, and at least you can narrow down your diagnosis to a few groups, though I doubt that you'll be able to make a pinpoint diagnosis at the level of general pediatrics unit, but at least you'd be able to pin it down to a group of disorders which can be then later on worked on by pediatric neurologists, and somehow later at some point in time definitive diagnosis can be reached. So without further ado, let's start and get started with this today's lecture. But before that, those of you who haven't subscribed to my channel, please do subscribe, and if you like my videos, then please share it with your friends. Now, moving on, the first thing is that you should understand what is the difference between a delay and a regression. Now, this is very, very important because many times doctors, they make a confusion. They make a sort of they can't actually differentiate between what is a developmental delay and what is a developmental regression, and this is very, very important because you need to know that you are really dealing with regression. And for that, remember that developmental delay basically is defined as a delay in achievement of milestones. Remember, so developmental delay is simply a delay. So the thing is that those kids, they are achieving their milestone, but they are a bit slow in this race. So they do achieve, but at a delayed time. While regression is loss of previously acquired skills. So it's a sort of a reverse gear. So a child reaches somewhere, he reaches a developmental milestone and then goes back. He reverses back in time to go back, and regressing. While delay is basically a slow. So that child is still moving ahead in time, but the only thing is that he's a bit slow. Now, remember that as far as this neurodevelopmental regression disorders are considered, they can be caused by a wide variety of underlying issues, which could be enzymatic, which could be genetic. And again, I mean, there are so many genotypes and there are so many phenotypes. It can, exhibit itself in a variety of different ways. Even within the same, let's say, if there is the same enzymatic deficiency, can present in different ways. Similarly, if there's a particular gene defect, again, there could be so many different phenotypes. So the presentation is very varied. It's very varied. So it's sometimes very difficult, like, if you get a varied presentation, from the presentation going back and understanding that, oh well, fine, this is pathognomonic of this type of disorder. Very difficult. I mean, you have to do a lot of workup. Usually the diagnosis is not very simple. Usually they are like, where you suspect a neurodevelopmental regression, and by the time they are actually diagnosed, the time difference between them could be sometime 2 to 3 years. So it takes a lot of time and a lot of workup before you can pinpoint the diagnosis. Well, this is actually causing the neurodevelopmental regression. Now, how a child grows, basically, as far as neurodevelopment is concerned. I mean, there are different possible pathways. I mean, if you look at this diagram, you can see a normal child from birth onward till his adulthood, he would slowly and gradually progress. So there are milestones which he achieves at different points in time. So for example, he starts sitting with support at around 6 7 months of age, starts crawling at around 9 10 months of age, starts standing at around, let's say, 11 12 months of age, and starts walking and running and so on and so forth. So there are specific times at which they achieve those milestones, whether they are gross motor milestones, whether they are like fine motor milestone, or whether they are social milestone. But anyhow, they do achieve it at particular times, and eventually they reach their normal. So this is the normal trajectory. This is the normal pathway of neurodevelopment. Sometime what happened while they are growing, at some point in time, let's say because of some reason, there is an insult to the bodily systems, and what happens is that that insult leads to a sort of a break in the development, but it's a static one. So wherever that child has reached, it would stop over there, and then it's static. So a static lesion where you had a sort of a neurodevelopmental up to a particular age, but after then there is a plateau. So we call it as a non-progressive. Non-progressive simply mean that it is non-progressing. Whatever has been achieved has been achieved, but after that there is no achievement. It just like remains static over there. Some types of conditions which result in early life insults to, let's say, especially the brain, again they can exhibit in what we call as non-progressive insult, but the milestones are stopped at an early age. For example, different forms of cerebral palsy, I mean that's one of the greatest examples where because of some defect, structural defect at the brain, but because it's a non-static lesion, it's a static lesion, what happens is that the development stops at an early age, and then the child his development remains at the same age where it stopped. And even if the child chronological age goes, even if he becomes an adult, his neurodevelopment is of that early childhood age, that typically, as I told you, we see it in cerebral palsy. And then we have got this developmental regression trajectory. So what happens here, if you look at this pathway, so here it is actually going down. So this is basically not a plateau. I mean, things are reversing back. So whatever has been achieved is going back. Now the time is progressing, but the milestones are going back in time. So this is actual regression. So we have to ensure that we differentiate between these lesions over here, some of them which present at early life like CP, some of them can present at later life, and from developmental regression where there is true reversal of milestones. True reversal of milestones. This is very, very, very important. In any case where you come across a condition where you think that there might be some like form of abnormal neurodevelopment, then you have to ensure whether it's a static where the child has reached a plateau, or whether it's an actual regression where somebody had achieved milestone but now has gone back in time, and there is a reversal of those milestones. Okay, now moving on, how do these neurodevelopmental disorders they present? Number one, they can present at any age, but especially because we are dealing with pediatrics, there are certain groups of disorders which can present at a particular point in time. Like for example, if you see the West syndrome, it presents in early infancy. If you look at leukodystrophies, they would present somewhere between 2 and 5 years of age. If you look at Wilson disease, or if you look at subacute sclerosing panencephalitis, which is a complication of early measles, that usually presents like around between 10 and 15 years of age. So there are various age groups at which some of these disorders can present. But as I told you, they can present at any age. Now, typically, irrespective of whatever the disorders, they can usually present with a regression of the higher functions. So higher functions like, thinking, problem solving, these types of higher functions, they can regress. So that would lead to a decline in academic performance. That would lead to a decline in sometimes in social performance as well. It might lead to a decline in regression of the gross motor function. Like somebody who was walking is now crawling. It can result in regression of the social function. Somebody who was well mixing with his peers and other things, is now very much reclusive, doesn't like to meet people, has got his own stereotypes. Or it could be regression in language, like somebody who was speaking and talking, he cannot now talk. I mean, even if he talks, it's gibberish. Similarly, hearing and vision problems, somebody starts becoming weak in their eyes, start losing their eyesight, or they start losing their hearing. Or in majority of cases, there is usually a combination of all these things. So there might be certain gross motor milestone which are, there might be certain fine motor milestones which might be regressed, and again a combination of social, vision, hearing. So remember, you can have any combination of these, like depending on whatever is the underlying cause. It's also very important that we differentiate these things, because we are talking about neurodevelopmental regression. So we are basically focusing on the neuronal causes, the CNS and the PNS causes of regression, rather than something which is there in the periphery, like muscular reasons or neuromuscular reasons. So you have to differentiate from that. Like somebody who has developed a muscular dystrophy, but rest of the, so that is basically a muscular problem. So because of the dystrophies, if he is regressing back on his gross motor, we don't call it like neurodevelopmental regression. Basically, it's like a muscular disorder which is causing gross motor regression. But that's why we say that when we are talking about neurodevelopmental regression, we have to ensure that the cause is there in the central or the peripheral nervous system, rather than in the muscular or neuromuscular junctions, which can sometimes present with more or less the same pattern. But obviously in like neuromuscular or in muscular disorders, there is no involvement of the neurons, either the gray matter or the white matter. It's either at the like the neuromuscular junction or at the muscular level. So this also has to be differentiated from true neurodevelopmental regression. Now, some of the examples of neuroregression, like how would you know somebody has got neuroregression? Let's say a 6 months old who the mom says was smiling earlier. I mean, he developed social smile at 6 to 8 weeks of age, but I mean, now he's 6 months old, and for the last 3 months, he's not smiling. I mean, he looks around, but there is no smile. So that is a regression, because he achieved a milestone which was smiling, social smile, but yeah, it's not there anymore. So this is a regression. Similarly, a 2 years old who used to walk, he was walking, but he's not walking anymore, and now he's crawling for the last few weeks. So, and there is no injury. I mean, sometimes they can have injury or something. You have ruled that out, and there's no injury, but he's now crawling. Or an 11-year-old girl who recently started having issues at school. So there is an academic decline. She's started like developing behavior problems. Her behavior is an issue at home, with the peers, at school, everywhere. She's got poor academics. Well, she was doing all this like better a few years ago. 2-3 years ago, she was very good. I mean, she had good behavior, she had good academics, but now she has regressed on that. Another example could be a 7-year-old who had a fits for a long time. So let's say he had an underlying epilepsy. Now he has developed his clumsiness. He's got problem holding cups. He can't hold cups. He falls. He drops things. He has got difficulty in performing daily functions. And obviously, I'm not talking about like juvenile idiopathic arthritis. There's not arthritic changes which is causing this thing. Basically, everything else is fine. There's no trauma or any other reason like inflammation of the joints. And let's say with that, the intensity of the seizures has also increased despite being on like anti-epileptic medications, some things. Again, we are looking at neuroregression. So these are some of the examples which, when you are confronted with, you would be thinking that probably you are dealing with neuroregression. Now, here in UK, the British Pediatric Surveillance Unit criteria for neurodevelopmental disorders is very clear. So they say, and you should remember this thing, I mean, who needs to be considered for these things. I gave you some examples, but then there is a criteria. And that criteria is an excellent criteria, because if somebody fulfills this criteria, then obviously they need further workup. So any child, anyone less than 16 years of age who fulfills the following 3 things. Now, all of these 3 things have to be present. Remember, these 3 things have to be present. So the first thing is that number 1, he has got progressive deterioration of more than 3 months. So there should be a history of whatever deterioration, whether it's muscular, whether it's fine motor, whether it's social, it should be present for more than 3 months. So the history should be of 3 months. This is number one. Number two, there should be loss of already intellectual or developmental ability. So you are talking about something which was already achieved. It's not like somebody says, oh well, fine, he's not walking, but if he was never walking, that is not a regression of the milestone. But if he was walking in the past but now he's not walking, that is a reversal. So there should be a loss of already attained something which the parents say yes, he was able to do but now he cannot do. So this is very important. And number third is that he has got abnormal neurological signs. So you find that he's got seizures, or he has got spasticity or hypotonia or loss of deep tendon reflexes, etc., etc. But it should be excluding static intellectual loss, like for example, which can after like a CNS infection. Encephalitis can happen with head injury, like post-concussion syndrome or near drowning. So you have to exclude these things. So once you've excluded these things, and somebody who has got a history of loss of what you call previously acquired milestones for more than 3 months, and he's got like abnormal neurological signs, yes, that needs to be further worked up. And this includes children who meet this case definition even if specific neurological diagnosis have been made. So if already somebody has been like, somebody said, oh well, this is a CP child, or he's been considered to be CP, but he's fulfilling on this criteria, he needs to be further worked up to see what is actually going, because that CP was most probably a mislabel. It also includes metabolic disorders leading to neurological deterioration. So metabolic disorders like galactosemia, hereditary fructose intolerance, things like that, which can lead to neurological deterioration, they are also included within this. It also includes seizure disorders if it is associated with progressive deterioration. If somebody had seizures and now they are developing psychomotor retardation and things like that, they have to be considered for this thing. Or kids who have been diagnosed as having neurodegenerative conditions but have not developed symptoms. So some kids, let's say for some reason, on some basis, some test was done and they were found that they were deficient in a particular thing, they are asymptomatic, but they are asymptomatic for the time being. They might develop symptoms later on in their life, so they are also included in this criteria. So this is the British Pediatric Surveillance Unit criteria. So remember this for your postgraduate exams, and especially if you are working here in UK, you should understand that this is a criteria on which you have to further work up. So if this is the case, then you have to discuss it with a pediatric neurologist, or a pediatric neurologist, or a community pediatrician who's got interest in neurodevelopmental disorders. So please keep this thing in mind. Okay, moving on. Talking about a framework for evaluating a child with regression. So the overall framework in which, like, this whole thing works, like, how it should be evaluated, is there are actually 4 domains. There is a domain of onset, there is domain of age at onset, then there are the further domains, whether it is the gross motor, fine motor, social, vision and hearing. And we also talk about somatic manifestations, whether they are associated with that or not, because certain neurodevelopmental regressions might have some somatic sort of side to it as well. Like, they can have visceromegaly, they can have organ dysfunctions like renal failures, things like that, hepatic failures. So remember, let's start with the age at onset. So age at onset, I told you that certain conditions can present at like in neonatal or early infancy, like glutaric aciduria type 1, or sometimes they might present in infantile age, like West syndrome, middle childhood, like leukodystrophies, or older child, like Wilson disease. Similarly, the onset can be an acute, like all of a sudden, deterioration in somebody who developed psychosis, and after that is unable to walk, unable to talk, hearing, everything is affected. So that is an acute presentation. Or it could be subacute presentation, like, where things have been gradually developing. Or it might be a chronic one, like, where things slowly and gradually over a period of months to year they develop. Similarly, the domains could be, it could be a gross motor domain, where primarily the gross motor function is affected. So these kids, they cannot walk, they cannot crawl, they are bedbound. Or it could be fine motor, where they've got clumsiness, they are not able to write, they're not able to hold the things, they're not able to do their daily routines. Or they might be social domains, where they are reclusive, they are they are not interacting with their peers, or it could be combination of all these things. And somatic means, like, they can have epilepsy, they can have seizures, they can have uh, organ enlargement, renal failure, hepatic failure, cardiomyopathy, so on and so forth. Then coming down to the practical approach to diagnose, and this is very important, because in the district general hospital, I mean, let's say the British surveillance criteria, you went through that. Now, how do you further work up this thing? So remember, emphasis on a thorough history and physical examination, which is the most important. So thorough history and physical, again and again and again, a thorough history and examination. Now, what key areas in history would you like to know? The number one, you always talk about the current concerns, like what is the concern, which particular areas have regressed. Like, is it gross motor, is it fine motor, is it speech and language, is it like social domains? How did it start, whether it's been acute, whether it's subacute, whether it's chronic, and how have been the things progressing over a period of time. Past medical history is also very important, especially you go through the antenatal history, birth history, and postnatal history. And after that, you'll talk about vaccination history and drug history. Because to see there could be certain reasons for that. Like somebody, a teenager who has been experimenting with certain types of, let's say, recreational drugs, he can present with something, an acute presentation of psychomotor retardation, which you might think looks like a neurodevelopmental regression, but in fact, that is caused by the side effects of a drug. Remember, on a general level, usually neurodevelopmental disorders have got, like, they present in such a way there is nothing significant in the antenatal, natal, and postnatal history. And this is quite in contrast, where you would find, CP childs have got something either at the antenatal level or the birth level or postnatal. Like a child whose mother had like infections in the antenatal period, and that leads to static insults to the brain. That child would be born with a microcephaly. Obviously he goes on to have spastic diplegia or quadriplegia. That's a CP child, a static. Similarly, something happened at the time, like hypoxic ischemic encephalopathy. Again, that can lead to this broad term which we call a cerebral palsy, a static insult. So usually in neuroregression, there's nothing in the history, especially the past history. There's nothing. Everything has been fine, because usually they are either genetic in origin or whether they are enzymatic in origin. You also look at the developmental history. So you take a detailed history at what age they achieve the milestones, and when they did start going back on those milestones. And similarly, family history also very important, because enzymatic, most of them would be either autosomal recessive, so there might be history of consanguinity, or there might be a family history of kids dying at an early age. That alerts you that probably you are dealing with some form of enzymatic deficiency. As I said, like most of enzymatic deficiencies are autosomal recessive in nature. And as I said, this is important because many times I've seen it, and I've seen it myself as well. Many times kids with like slowly progressing neuroregression, which is processing as slow, they have been misdiagnosed as cerebral palsy. Misdiagnosed, especially more so in developing countries. They would label every other child who's got some form of neuro as cerebral palsy. Though in fact, it's not cerebral palsy. It's basically a neurodevelopmental regression. So it's very important to differentiate between these two. So it's important to know whether these milestones were never achieved at all, or whether they were achieved and then the child reverts back on those milestones. And it's also important that you label whatever has been lost, you fit it in its own appropriate category. Child who cannot walk, gross motor domain. Child who cannot do his daily routine, fine motor domain. Child who is clumsy or tends to fall with weak vision, okay, fine, it goes in the domain of vision. Hearing problem goes in hearing. Somebody who's like having like issues with interacting with the other people become social domains. So whatever has been lost, you have to put it down in their respective domains to see what basic domains have been affected. Okay. Further practical approach to diagnosis, again, depends on the age at which regression was first noted. I told you few cases can be clumped together to give you an idea which causes they present at different age groups. Though it's not a rule in general, but that can help you in narrowing down the diagnosis. And it's also important that you exclude peripheral causes, like somebody who had a hidden fracture, not walking, but not walking is simply because there's a hidden fracture. The child is so young he cannot tell you, or there is a bone cancer because of which the child has got pain and he cannot walk, or there are peripheral causes which can affect vision, like for example the child has got a cataract or he's got hearing problems or speech problems because of, let's say, being born with some like oral deformities which is affecting his speech. So again, you have to exclude things which can mimic neurodevelopmental regression. And once you have excluded the peripheral causes, it's also important to know whether the predominantly gray matter is affected or white matter is affected, because when we talk about neurodevelopment, remember we are dealing with the neuron, and the cell part of part of the neuron is basically your gray matter, and the axon part is the white matter. So you have to see whether the neuron as a whole is affected, where it would be a gray matter and white matter involvement both, or it might be predominantly gray matter involvement where the cell body is affected, or it might be a predominantly white matter disease in which the axons are primarily affected. So how do we know? Basically, ideally you do an MRI for that, and that gives you an idea whether there's a predominantly gray matter involvement or white matter involvement. But again, there are a few clinical things as well by which you can differentiate whether you are dealing with a predominant white matter disorder or a predominant gray matter disorder. So age at onset, like usually gray matters, they present at an early age. White matter usually present at a later age, like around after 2 years of age. Similarly, if you look at head size, though this is not a rule, most of the white matter disorders kids might have like big heads. Macrocephaly. Gray matter disorders, usually because the gray matter is being lost, they have got microcephaly. Seizures are usually, they present like kids who have got gray matter issues, they usually have got early and severe seizures, they present early in life. White matters, usually if they have got seizures, usually present at a later age. Cognitive functions usually are normal in case of white matter disease because the axons are affected. If the gray matter is affected, these kids are intellectually impaired. So there is progressive, either if there was something, now they are regressing back and down. So there is always an intellectual impairment. Peripheral neuropathy, obviously, because white matter presentation would be early because of obvious reason. Usually it's late in gray matter. Similarly, reflexes, white matter reflexes, usually deep tendon reflexes are absent. In the gray matter, they are usually normal or exaggerated. Cerebellar signs are usually early in white matter disease, but they are usually late in gray matter disease. Similarly, rest of the things, if you look at this slide, that gives you a very good clinical differentiation between white matter disorders and gray matter disorders. Okay, so much of these things are pretty much self-explanatory. Now, coming down to the practical approach. Now, if you are somebody who fulfills the criteria for the, I told you the British PIND surveillance criteria, who needs to be further worked up or checked for neurodevelopmental. So, if somebody who fulfills that criteria, so there is a history of more than 3 months, and they've got like a loss of previously acquired functions, then what you do, you will take a thorough history, you will do a thorough physical examination, and based on what you find in that physical examination, you will look for certain things, and then you, based on that, this algorithm would help you. Like for example, during when you are examining that child, and from a part, not only like you check his what you call his neurological system, you check his abdominal, respiratory, everything. So if there is visceromegaly, and by visceromegaly I usually mean visceromegaly, usually hepatomegaly. Okay, if you can feel for the liver, a child who's got neurodevelopmental regression based on that criteria, and the liver is enlarged, then the next step, look for dysmorphism. See if his face looks a bit abnormal. So if it is looks like abnormal, like if you feel like it's a Hurler phenotype, thick lips, broad forehead, things like that, I will come to that later on. But let's say if his face looks normal, there's no dysmorphism, then the next best step would be to check urine for reducing substances. So if the urine reducing substances are positive, you're probably dealing with galactosemia or hereditary fructose intolerance. But if the urine substances are negative, and this child has got enlarged liver, you do a bone marrow aspirate for Gaucher cells. So if the Gaucher cells, which are basically the cells, the white blood cells, have got sort of a particular appearance, they call it if I'm not forgetting, crumpled paper appearance. So if there is a crumpled paper appearance inside the cytoplasm, that is what we call as Gaucher cells. So if that is present, you are dealing with Gaucher cells. If it's not, like if there are more vacuolated structures within the cytoplasm, and there are no Gaucher cells, you're probably dealing with Sandoff syndrome or probably Niemann-Pick syndrome. Now that makes it easy. I mean, at least you know a few groups of disorders that you are dealing with that. So that's how you look for if a child has got visceromegaly. If he hasn't got any visceromegaly, then you just look whether the child has got any abnormalities of skin and hair, like for example, fragile hair or fragile skin. Okay, and I will come to that later on, that if it is fragile skin and hair, so different type of disease like Menkes hair, biotinidase deficiency. I will come to that later on. So anyhow, if there is visceromegaly, remember, check for dysmorphism. If there's no dysmorphism, check urine for reducing substances. If positive, you know what you're dealing with. If not, bone marrow, and that would give you an idea. Okay, moving on. If it is the Hurler's phenotype, if it like thick lips, broad face, broad forehead, then you might be probably dealing with mucopolysaccharidosis. So the best thing would be to do a urine berry test. Basically, that actually looks for mucopolysaccharides in the urine. So if it is positive for that, then you are obviously dealing with mucopolysaccharidosis, probably Hurler and Hunter's. If not, then you should be looking for oligosaccharide, not polysaccharide, but oligosaccharide. So if oligosaccharides are positive, you're probably dealing with fucosidosis or sialosidosis. These are the two, disorders of oligosaccharides, which can give you neurodevelopmental regression. But again, even if there is no positivity for mucopolysaccharides and no positivity for oligosaccharide, then you are probably dealing with not oligosaccharidosis or mucopoly. You are basically dealing with mucolipidosis. So either you are dealing with mucolipidosis or GM1 gangliosidosis. If there is no Hurler phenotype, remember, no Hurler phenotype with visceromegaly, then you are either dealing with Zellweger syndrome or neonatal adrenoleukodystrophy. Again, I don't want to overwhelm you with what Zellweger syndrome it is, what neonatal adrenoleukodystrophy is, and what enzymes are deficient in that. Just remember, because you at a district general hospital, you're not basically responsible to look at the enzyme or do these enzyme assays. That will be done at the tertiary, but at least you know what broad level of diseases you are dealing with. If there are abnormalities of skin and hair, yes, if you see that there are fine hair, grayish, brownish, or blonde, then probably you might be dealing with Menkes kinky hair syndrome, which you got brown kinky hairs, or it might be a feature of biotinidase deficiency. It can also occur in Fabry's and Cockayne syndrome. If there are no abnormalities of skin and hair, and the child has got no visceromegaly, then the most important investigation that can be done at a district general hospital is an MRI of the brain. So MRI is one of the best thing, and you should remember this one investigation and should be able to interpret that. So if the MRI brain shows demyelination, okay, then again, you should know what you're dealing with. But if it doesn't show any demyelination, I will come to that. Like if the brain MRI is normal, then you would check the eye. So obviously you checking the eye means that you need to refer him to the ophthalmologist so that he looks at the retina and looks for any retinal pathology like cherry red spots and things like that. So if the ocular pathology is present, again, there is a different group of disorders that you would be dealing with. If there is nothing, eye examination is normal, then again you look whether seizures are present or not. So if seizures are present, you're probably looking at Lesch-Nyhan syndrome. If seizures are not present, then you might be looking at juvenile Huntington disease or mitochondrial cytopathies. If the MRI shows demyelination, let's say there is some form of demyelination, then you look at the head circumference, whether the child has got a big head or a small head or normal head. If the child has got a big head, you're probably dealing with the white matter disorders, predominantly white matter disorders like Alexander disease or Canavan's disease. If it is microcephaly, it might be congenital HIV. But if you're dealing with a normal head size, again, you look whether the child has got seizures or no seizures. So if its seizures are cardinal signs with a normal head and demyelinating, changes on an MRI, usually Krabbe's disease, subacute sclerosing panencephalitis, and mitochondrial cytopathy. Some of the mitochondrial cytopathies can present with seizures as well, and obviously the head size would be normal. Krabbe's disease is a condition in which presents in infancy. The kids are very irritable. They usually have got unexplained fever, like fever without any reason, recurrent bouts of fever, but there is no reason, like all the workups comes out normal, but they are very irritable and they've got neurodevelopmental regression. Subacute sclerosing panencephalitis occurs usually after 10 years of age and occurs as a late reaction to measles. So somehow measles antibodies, they actually react against the neuronal cells. If there are no seizures, then you probably are dealing with metachromatic leukodystrophies or the infantile or the childhood forms of adrenoleukodystrophy. How to investigate? So I told you the best thing would be to do an MRI, because MRI gives you the most important diagnostic information, and from that onward you can then tailor up your work and you can do rest of the diagnostic workup. Sometimes you might see typical dysmorphism and associated clinical features like obviously Hurler syndrome, Hunter syndrome. You just look at them and you probably can pick it up what you are dealing with. But remember, step-by-step approach, as I described earlier, like starting in an algorithm is the best thing, and multidisciplinary approach. It's not you who are dealing. Obviously, you might have to include the pediatric neurologist, the community pediatrician, again, and other people in your workup as well. Then some of the important patterns that you should know for the MRI brain is that predominantly in case of predominantly frontal involvement. If you see here, if you see there is predominantly frontal white matter involvement, you can see here, I've just highlighted here in yellow. So this is a predominantly frontal involvement on MRI. So if there is a predominant frontal involvement, that usually happens in Alexander disease. So Alexander disease, remember, always frontal involvement. If there is parieto-occipital involvement, posterior, remember, I can simply see A stands, A comes at the front. So A would be at the front. So frontal means Alexander. X-linked adrenoleukodystrophy, because X comes at the end. So this is the end of the brain, the parieto-occipital area. So predominantly parieto-occipital area, if that is involved, you are dealing with X-linked adrenoleukodystrophy. If you see there are predominantly subcortical involvement, so see there is not like cortical but subcortical diffuse involvement on both sides, you are probably dealing with Kearns-Sayre disease. Or if it is predominantly periventricular involvement of the white matter, you can see predominantly periventricular, then you are probably dealing with metachromatic leukodystrophy. So these are some of the patterns. So just remember, frontal involvement predominantly Alexander, parieto-occipital is mostly for X-linked adrenoleukodystrophies. Sometimes it can also occur in Krabbe's disease as well. So remember, it's not written over here, but let me write Krabbe's disease can also have parieto-occipital involvement. Subcortical involvement, Kearns-Sayre disease, and periventricular involvement is metachromatic leukodystrophy. So just remember these four things, and these cover most of the things. I hope you have understood that. Moving on. Treatment. Now, treatment is multidisciplinary. Treatment, because these are neurodegenerative conditions, you would require the input of a community pediatrician, you would require the need of a pediatric neurologist, a dietitian, physiotherapist, occupational therapist, GP, community nurse. I mean, this is generic answer for these guys because this is a lifelong treatment and they would be on some form of treatment for the rest of the life. But there are a few specific treatment for examination point of view. Remember these things, they can, like for Krabbe's disease, bone marrow transplantation. Similarly, for metachromatic leukodystrophy, bone marrow transplantation is the specific treatment modality. If you are dealing with adrenoleukodystrophy, again, it is experimental, but they say Lorenzo oil or glycerol trioleate or steroids. You can, for adrenal part of this leukodystrophy, you can give steroids because they've got adrenal insufficiency as well. You have to give them diet which is low in very low chain fatty acids, and bone marrow transplantation can also be tried in adrenoleukodystrophy. But remember, Lorenzo oil is something which has been tried with some varying results in adrenoleukodystrophy. As far as mucopolysaccharidosis, Hunters are again bone marrow transplantation or enzyme replacement therapy is something that works. For Menkes-Kenke hair syndrome, you have to give them copper and histidine. Similarly, for mitochondrial cytopathies, different types of vitamin B complex like nicotinamide, riboflavin, or L-carnitine, along with coenzyme Q10, they work. Wilson disease requires chelating with D-penicillamine, and because there is predominantly liver involvement, that might need liver transplantation as well. For Refsum disease, you need to reduce your phytanic acid intake. For Lesch-Nyhan disease, in which there is self-mutilating behavior, and uric acid is quite high, so you need to give them allopurinol. And similarly, for Fabry's disease, you need to give them recombinant human alpha galactosidase A, because that's the enzyme which is deficient, and that can help in, rather than, if the reversal gear is going very fast, at least it can bring it to a static level. Maybe sometimes might reverse as well. That's a bit controversial, but anyhow. So this is the specific treatment which is given in the some form of neurodevelopmental disorders. So this was a short lecture in which I gave you an overall view of neurodevelopmental disorder. So the crux of this talk is that you have to differentiate between what is a static condition and what is an actually regression, or in other words, what is a delay and what is a regression. So you have to differentiate between these two, and I give you some algorithms that, based on a good history and physical examination, you start with visceromegaly, and if visceromegaly is present, if it's absent, how do you approach that? If you also look at the abnormalities of skin and hair, and you do an MRI, and based on the MRI and seizures and the head circumference, that can give you different clues that what you are dealing with. And then we also talked about different forms of specific treatments, which obviously you should remember from academic point of view. So I hope you have at least understood something about neurodevelopmental regression. Again, I told you this was a disclaimer. I mean, I don't want you to become a super specialist in neurodevelopmental regression. I mean, it's a very, very broad area. I mean, people can write like volumes of book on these issues, but just wanted to have an idea so you know what you are dealing with. Anyhow, I hope you have understood something. If you still have got some queries, questions, or something, you can put it down in the comment section below, and I will try my level best to answer them. Have a very good day, and bye-bye.